don't have request to play media in this presentation.
No, that's fine. I'll give it to you. Don't worry. It's just a video.
Cool. Okay.
Okay, so we should now be live. Thank you everyone for joining us in this webinar, Exploring the Healthcare Careers by In2MedSchool. Welcome back if you're one of our subscribers, our mentees, and welcome for the first time. If this is the first time that you follow us, please hit the subscribe button so our subscribers can go up. And welcome again. Today, we will explore different healthcare careers, including nursing, midwifery, medical science, and more. And this will be moderated by Sharms and I, who, as many of you know, are the healthcare coordinators of In2MedSchool alongside Thea. Next slide, please. So who we are and what do we do? We are a team of more than 2,500 students across the UK who offer free mentoring sessions to disadvantaged Year 12 and Year 13 prospective medical students. We do so by offering one-to-one mentoring sessions, online webinars like this one, and many educational resources in order for you guys to be as prepared as possible for your medical school application. Next slide. So just remember the webinar etiquette. I'm sure if you followed us through the year, you remember these things. However, we still ensure to remind them at every webinar. First of all, please use appropriately the chat and the Q&A function. We've disabled the YouTube chat for your safety. And please use the Slido if you want to send any questions. The Slido code will be at our next page. Please remember to be professional and kind to our volunteers. Many, particularly today, are healthcare professionals, and they're giving up their time to dedicate it to you guys. So always remind to be respectful. Next up, just a reminder that we have a Q&A session at the end, so keep your questions for that time. And also a small reminder that this webinar is live on YouTube and will stay on YouTube to watch at a later date. A certificate of attendance will be sent out to everyone that completes our post-webinar evaluation form. Next, just a little disclaimer that the views expressed by the speakers involved in our event are entirely their own opinions and accounts of professional and personal experiences. Therefore, they do not represent the views of any university, and they do not necessarily reflect the official policies or positions that In2MedSchool holds. And next, In2MedSchool has no affiliation to any university. So, as I said, please feel free to send us throughout the events questions on our Slido. The code is I2MS Careers, and there we will be able to collect all of the questions that we will just ask our speakers during the Q&A session at the end of the webinar. So we have the first speaker, Sian, who's a midwife, and we welcome her. And again, thank her so much for her time that she's taken on a Saturday afternoon to dedicate to you guys. So take it away.
Hi, thank you, Anna. So yeah, hi everyone. My name's Sian. I am a midwife. I'm also a nurse as well. I'm dual qualified. So I kind of wanted to give you a bit of an insight into what midwifery is like, about kind of what midwifery is about, what a kind of day-to-day life is for a midwife, talking a little bit about the history of midwifery as well, and also just kind of covering a bit about career progression and some of the changes that is going on in midwifery at the moment as well. So to start with, what is midwifery? So midwifery actually kind of comes from a very old profession. Midwife literally means to be with woman. A lot of people before used to kind of get a bit confused with kind of midwifery, that thinking that it's a very female dominated area. And at the moment it still is, but it is becoming more and more diverse, which I think is really important, that we're having more and more demographics of people, actual birthing people, who might not identify as a woman. So I think it's really important that we're kind of moving away from the birthing language, that women are our primarily clients, which actually we're also seeing a lot of trans men as well, who are part of our birthing clientele as well, and some people that don't identify as necessarily a woman. And also we're having a bit more of male midwives now, which is really important as well in the career of having a more demographic people that can relate to people on a more personal level. before, when I started training, and people would say to me, oh, you know, I'm not sure a man could become a midwife. And I would say, well, why not? And they would say to me that they would felt that they've never had a baby before, so how would they be able to relate to women? And I found that actually I've never had a baby before. So it worked quite, I kind of felt, why would it make me less of a midwife, or make a man less of a midwife? So I think it's really important that we get more diverse staff in midwifery to be able to appeal to all of our clients. I put up a little picture of a molecule. This is oxytocin. This is our big molecule that we use in midwifery. It's our love hormone. It's the one that we idolize in midwifery. Midwifery, a lot of people just think it's about delivering babies, and that is a big part of our job, but most of it is kind of covering a massive scope of women's journeys and birthing people's journeys. So we look after our clients from antenatal periods. So this is when they're pregnant, they book in with a midwife, and we refer them on to specialist services. We then look after them all the way through their pregnancy. We look after them in what we call the intrapartum period. This is their labour, and we will look after them all the way up until delivery. And we also then look after them postnatally. We are responsible as midwives for looking after our clients up to 4 weeks postnatal. After that, they are handed over to health visitors and GP services. We also cover neonatal care. So we work alongside the neonatal services. We look after babies on our units and also at home. I will briefly touch on a little bit about bereavement. This is part of midwifery, unfortunately, and it's one of the sad parts of it, but I'll touch on it. And when I come up closer to the time where I'm going to speak a little bit more in detail, obviously there will be a trigger warning. You know, if you find that this particular bit is upsetting, you can just mute if you need to. So next bit, I'm going to talk about just a brief bit about the history of midwifery on the next slide. So midwifery, like I said, is a very old profession. We have been birthing babies for thousands of years, ever since the start of mankind. So the oldest mention that we found is from ancient Egypt, where there were texts that showed a lot of the birthing process. And from then on, it was very much predominantly a female role, that women would look after other women, delivering babies. Up until about the 18th century, this is when more surgeons came about, and there was quite a bit of conflict between obstetrics and traditional midwifery practice. That has now developed into a much better cohesive pattern. We as midwives now look after normal births, and this term's not always liked by us midwives. We find that sometimes by calling it normal, you're making women that don't have a vaginal birth abnormal, which I think is not very fair, but it's very difficult to make up another term. Basically, whenever a birth is going normally, you're looked after by a midwife. Anything that becomes abnormal is when we would refer on to an obstetric team. And midwife is now a protective term under law. So no one that isn't registered should never use the term midwife, which I think is very important to our personal practice, that we feel protected as a group of people. The next bit I'm just going to talk about is kind of my journey into midwifery, and how I came about with what I wanted to be a midwife. When I was at school, I really wanted to be a doctor, actually, to begin with. I found that was the healthcare profession I really wanted to go into, but I didn't have much idea about it. I came from a family that didn't have anything to do with healthcare whatsoever, but I really loved biology, chemistry. Those were my favourite subjects, and I found it very interesting. So I did lots of work experience, and actually, as I was following a lot of the doctors, I actually found myself drawn to nurses, as actually when I was doing the work experience. And I kind of thought, what was the reason that for me that wanted to kind of go into a nursing profession to begin with? And I felt I really loved more of the patient care. So I found, obviously, with our doctors who do a fantastic job day in, day out, that they were looking into more the investigative bit, the diagnosis, and then putting in plans. As a nurse, I found I was really drawn to the idea of being more at the patient's bedside, and actually implementing that care. And that was a big draw for me to become a nurse. So I actually then trained as a nurse, as you can see on the PowerPoint, from 2013 to 2016. From then on, I went and became a gynecology nurse, and I worked there for a year. And during that time, I was making up my mind whether I wanted to become a critical care nurse or an A&E nurse, or whether I wanted to change my profession and become a midwife. I was kind of drawn to the idea that when I worked as a healthcare assistant, on labour wards alongside my nursing student career, that I was drawn to it, and I found it very interesting. It was a very different kind of field of how we look after people. Nursing is all about looking after ill people, and obviously in midwifery it was very much these are well women, we are helping them birth their babies. So during my time as a gynecology nurse, I realised I really loved looking after pregnant women, really loved caring for them antenatally. So that's when I decided I was going to become a midwife. I then trained as a midwife. I did the shortened course because I was already an adult nurse. And I have now been working in the NHS since August 2019 as a midwife. Recently received my band 6 position, which means I'm no longer a junior midwife, which is lovely. And I look after women. At the moment, I'm on labour ward, currently on night shifts at the moment. So just popping in to say hello to everybody today. And yeah, that's kind of my career so far. See where I go next. So what I'm going to talk to you about next is kind of the day-to-day ins about midwifery. So starting with antenatal care. Antenatal care is, like I said, it's the pregnancy part for women. So we're looking at things like on a day-to-day basis for our antenatal midwives. They're looking at taking a history for the woman. It's very detailed in midwifery. We love to know all of their history, and how many babies they've had, how many live births they've had, if they've had any, unfortunately had any miscarriages or stillbirths. We also perform abdominal palpations, which is the picture that you can see on the slide here, which is a big part of midwifery, that we ask women to have a feel of their stomach. So we can palpate and see what position baby's lying in. It's obviously very important. As you can see with all these babies, they're all actually facing head down, which is the main point that we want most of these babies to do. But occasionally we do have them where they're upside down, and then we have to refer them on for specialist services. So lots of parts of midwifery is we're seeing women very regularly through their pregnancy to make sure that we are covering them from a safety point of view. Antenatally, we may offer them a vaginal examination or speculum to see if their waters have gone, or to see if they're in labour. We also give them antenatal education. I think this is really important, and unfortunately with COVID at the moment, this has become worse, being able to provide it. Luckily now with a lot of technology, we're able to do more Zoom meetings, but antenatal education was such a big part of midwifery that we are able to inform women of all of their choices in their labour and their postnatal period. So unfortunately with COVID going on, there is a lot of lack of this, but at the moment you can see the amount of information resources that have been put online is fantastic. And obviously what I've put on here as well about escalation. So as like I said, midwifery, we tend to work in the normal labour, normal pregnancy. If there's any risks, this is when they're referred on to high risk care. People like our doctors, our physiotherapists are very important as well. We get a lot of women with pelvic girdle pain. So that is where baby tends to be sitting very low and causing quite a lot of pain in their pelvis, and where their kind of the symphysis pubis, their bone at the front, sometimes splits a little bit with the weight of the baby. So we refer them on for that as well. Occasionally as well, you might have some women become unwell when they're pregnant. So we also can refer them to medical teams, surgical teams as well. And as midwives, we work with social care as well. So women that are deemed to be needing social services, referrals, we work alongside them, and mental health visitors as well, and health visitors. So the next bit is probably the bit that most people know about, which is our intrapartum care, which I've popped on the next slide. So this is about looking after women in their labour. So when women come into the unit, whether that's either at home or at hospital or birth centres, we're assessing them for risk. And that's a big part of our midwifery job when they first come into us. And this is kind of triaging them essentially. We can categorise them into what we call obstetric-led or midwifery-led. If it's all kind of going normal, they become midwife-led. This means they kind of are treated as a very low-risk birth. If, however, they're seen as high risk, they tend to be referred into the hospital. This can be for a multitude of reasons. Unfortunately, I don't have time to go into all of them, but there's lots of different reasons that they might need to be obstetric-led. And what the main part of the midwife is that we would provide them with their options, and we manage their labour really safely. A big part of my job that I love to do when I'm looking after women in labour is not just providing them with a safe care, but also giving them a good birth experience. I'd hate for a woman to go away feeling very traumatised by a birth, and it's very difficult to work out what kind of level of trauma that some people experience. Sometimes I've witnessed births that I think were quite traumatic, but that woman said, no, that was fine. I understood everything that was going on. I felt very well informed, even though it was very all over the place. And other women that I thought was beautiful births have said they found it quite traumatic. So it's very interesting seeing different people's perceptions. And I found that the majority of, as long as we're informing these women and giving their options, explaining why we do things and why we recommend things, it makes their experience so much better. I put a little bit of the statistics on here to kind of show you actually how much of the majority of our babies are born in the UK by a normal delivery. So this is when we call an SVD, which is a spontaneous vaginal delivery. Over half of babies in the UK are born this way. We also have ventouse deliveries. This is quite a small percentage, but this is where we use a suction cup, goes on top of baby's head, and an obstetrician will use that to help mum deliver the baby. Forceps is, quite a lot of people know what forceps are, but they're essentially kind of like a metal cradle that sits around the baby's head, and the doctors will pull alongside the mum pushing. And then we have our, what we call on here, ELCS, which is our elective caesarean section rate, and our emergency caesarean section rate, which is fairly high in the UK, but we are much better than the majority of the world. The main thing that we're trying to do at the moment in the UK is trying to lower both of those rates down. Elective sections tend to be the ones that are routine, outside of the labour ward, day-to-day business. It's very kind of between 9 to 5, but they're going to be quite hard to reduce down. Those women are kind of planned caesareans for a multitude of reasons, like their placenta's low, their baby might be breech, like I said about the baby upside down. So it's quite hard to reduce that as much as we can, but the emergency section rate is definitely something we're trying to reduce, and trying to obviously reduce instrumentals like ventouse and forceps. That's a big part of midwifery, trying to reduce it as much as we can to make it safer for babies and mums. Like I've put on here about the majority are overseen by a midwife, because obviously most babies are born normally, as such, as you can say, for our vaginal deliveries. So we generally look after most mums, and we refer on if we need to. So I think sometimes our doctors get a bit of a skewed view of birth. They obviously only see abnormal. They see births where the heart rates of babies are problematic, or mum's unwell. So I get to see quite a lot of different births. I get to see births that are beautiful and very smooth sailing, and we also get to see some slightly higher risk births as well, which is what I quite like about my job, that it's so varied, that I will have some women someday that will come in and they will be fully dilated already and have a baby very, very quickly, and some women I get them going all the way through their pregnancy and we end up having a lovely delivery, but it obviously takes a long time, and sometimes things aren't going totally, the right way, so I refer on and we still have lovely deliveries, and sometimes it's not as great as we'd like, but we try and get it as best we can and make sure mum and baby are safe. That's our biggest priority. Midwives also do a lot of high dependency care, so mums that are unwell during their labour or postnatally, we look after them in high dependency. If obviously they are becoming incredibly unwell, they're referred on to ITU as well, which is our intensive care units. Obstetric emergencies, this is a big part of our midwifery career. We are trained every year in our obstetric emergencies alongside our doctors, and we work very collaboratively well with our doctors. I work in a fantastic unit where we work really well alongside each other for these emergencies, and they're dealt with normally incredibly well, and our rates for problems are going down. The next bit I'm going to talk about is about postnatal care and neonatal care. So this is another side of midwifery. This is the bit that some people kind of forget about a little bit, but it's a really important part of midwifery, is that we're looking after these babies after they're born, and we look after mums as well. So a lot of our big job postnatally is infant feeding, giving mums and babies the right information to be able to breastfeed if they wish to breastfeed, but also giving them some support if they do wish to bottle feed. Our big push in the UK at the moment is to get our breastfeeding rates up. My trust is very good. We've got about 80% is breastfed, which is fantastic, and we're just trying to inform more and more women about our breastfeeding, because we are working alongside the national guidelines for trying to improve our feeding rates. We work alongside our neonatal teams as well. So we have, which I put on there, SCABU, which is Special Care Baby Unit, and the neonatal unit. So we work alongside them to monitor for babies that do have to go to special care, and we're looking after mum. And we have sometimes babies that are there a long time, and we work out best plans for those babies and those mums. We also have transitional care. This is quite a fairly newish bit into midwifery, which is fantastic. It's looking after babies that are trying to stay with their mums So these might be preterm deliveries, and we're trying to keep them away from the unit, the neonatal unit, as much as possible, so they can stay with their mum for longer periods of time, which has become a really good part of midwifery, which we love. I've also put the same thing about the high dependency, and referrals onto other specialisms, and our education is really important. We work alongside social services, health visitors and GPs to work the best plans for some of these high-risk mums as well. Before I go on to the next slide, I'm just going to obviously do a little trigger warning. The next slide is about bereavement. So this is obviously part of midwifery that we do have to touch on a little bit. But obviously, if there's anyone that is affected, I'm really sorry. You can just mute for the next slide if you wish to. Yeah, I'm just going to briefly touch on it. So the next slide is about bereavement. So like I said, the majority of midwifery is a happy kind of job. We bring in life into the world. But unfortunately, there is a sad side to midwifery. We do have some babies that die in this country. Not always, we don't always find out why. There are a few times that we can kind of work it out, and there's lots of investigations that go into why babies die. Our UK stillbirth rate is around 3 to 4 babies per 1,000, which, although you may think, oh, that's quite a small number, that's actually fairly large across Europe and across the world. We have one of the highest first world country rates, which is quite shocking and quite sad. And we are doing lots and lots of research into figuring out how we can reduce that down back to some of the other countries across Europe that are much, much lower than ours. But it has got better. We've noticed year on year our stillbirth rate is going down, which is great news. We've also become much better at maternal death. We have, I mean, years ago, if you think centuries ago, maternal morbidity was very high, and we've actually been able to, due to lots of training, this has come down right down. So it's now only 7 per 100,000 a year, which is much better if you look back through history of what that could have been like. Particularly, it used to be a lot of problems with preeclampsia, which is high blood pressure through pregnancy, and these women would normally become very unwell very quickly. We are much better at identifying this, and actually now the chance of you passing away from preeclampsia and eclampsia is very low in this country now, which is fantastic news. We also cover in midwifery a little bit about choosing to end their pregnancy. So there's lots of different terminologies for this. Some people use termination of pregnancies, abortion, and also compassionate induction, which I think is quite a nice term that we use now for where baby has abnormalities and mum has decided actually this pregnancy isn't viable for this baby, or this baby's going to have very poor quality of life, or if it's making the mum very unwell. You have some mums that may be suffering from kidney failure, or and the pregnancy is making it worse, or they've actually found that they've got cancer and they wish to end the pregnancy so they can start their treatment. So compassionate induction or termination is also something us midwives carry out as well. Most units will have a kind of bereavement suite, which is away from the labour ward, and that gives those mums and dads a bit of privacy and their partners privacy away. Our role is to provide compassionate care. It's really important to be lovely and kind, and we work alongside our doctors to provide these clients with the best care that we can give them and the safest care, and we've helped signpost them to other services that they may need, so counselling, things like further testing if they wanted to know a little bit more about potentially why their baby died, and we provide that care for them as well. So the next bit I'm going to talk about is our types of, it's about how to get into midwifery. So midwifery has a couple of options now. It used to be very strict. Years ago, you had to become a nurse, and you then had to do the postgraduate diploma, which is the one I did. Now you've got 3 options to get into midwifery. So we have the undergraduate university degree, which is full-time, it's 3 years. Most universities across the country run this programme, and the majority of midwives now are what we call direct entry midwives, which is what this would be classification as. It's very competitive. There are less places for midwifery than nursing on most courses, so it tends to be very highly competitive. You need quite a lot of experience as kind of understanding what midwifery is about. It's very difficult to get midwifery work experience at the moment because you need to be 18 for a lot of the places to be actually able to go and see births or be in a hospital setting in a women's area. So you tend to find that actually just researching into it, thinking about maybe looking into stuff in the community like breastfeeding support cafes, things like that would be really beneficial, or just kind of talking to midwives and talking to other healthcare professionals that work in obstetrics and midwifery. And we have fantastic programs in this country to develop that. For the same for all of these options, the big requirement is you need to catch 40 babies. So that's the big one. And all 3 options, there's no short way around it. You have to catch 40 before you can qualify. And that's quite a bit scary for a lot of people. They think, oh, I've got to catch 40 babies before I even become a midwife. You're very well supported throughout all of these courses, and you would never be allowed to do a delivery on your own. The other option that's been brought out now is this midwifery apprentice, which is now a 4-year course, and it's fairly new, so I don't know the full details of it as much yet, but we've got a couple of midwifery apprentices at my trust who were our maternity support workers, who have decided actually they'd like to top up essentially and become a midwife. So it takes them a little bit longer, 4 years, but they're paid alongside it, so makes it a little bit better for compensation wise. And then there's also the postgraduate diploma, which is what I did, which is 18 months. Tends to be a little bit more clinical because I've got a kind of background theory as such from the nursing part, and so I'm just kind of topping it up with the midwifery, slightly more specialist area. But that is only available for qualified adult nurses. There's not many anymore doing it. I think there's about 7 universities now still doing that option, but that's another career option to have a little look into. And then looking further on for you about what types of careers are in midwifery. So I put that on the next slide, I think it's this one. Yes. So we've got a couple of different options. So there's the hospital midwife, which is what I am at the moment. I'm a hospital midwife. I rotate around all of these areas. So I rotate onto our antenatal ward, labour ward. Our birth centre actually at my trust is separate to the hospital. It's a little bit further away. Some birth centres are considered low risk and they're attached. We've also got a postnatal ward, triage, which is kind of like an A&E assessment, but for maternity. And then we have antenatal clinics, which is where our obstetricians and our specialist midwife will run clinics. And sometimes we have some like junior midwives, like, you know, when I was a junior midwife, you might help out as well in those areas. We've also got things like community midwives that go out and work in their clinics. They provide home birth services and postnatal care in the community. A lot of their kind of developing into more continuity teams now, which is fantastic. It's where women are more likely to follow a midwife all the way through their pregnancy, and even be with them at the delivery as well, which is fantastic. That's a big push at the moment. We've got independent midwives. So this is not very many, and unfortunately they have had quite a lot of difficulties with getting insurance, but there are some fantastic independent midwives across the UK who provide a private service outside of the NHS, alongside sometimes working with us as well, and they provide private care for some of our ladies. We've also got specialist midwives. I mean, there are so many options of specialist midwifery. We have mental health, infant feeding, I popped on there, I think twins, yet smoking, safeguarding. There's so many. Each demographic area will find they'll have a couple different more that might be more specialised to what they're seeing in the community. So diabetic specialist midwives tend to be across most units, but things like I'm trying to think of like a that we have one that was like a refugee asylum seeker midwife, because one particular area had so many clients, and to give them more continuity, they felt actually it was really important to have a more specialist midwife to kind of give those clients a much better pregnancy experience. We've also got managerial roles, so midwifery can go up. You can become ward managers, matrons, consultant midwives tend to run lots of projects in the hospital, and then we have our head of midwifery as well. Some other roles that midwifery can get you into. So one of our midwives went off and became an advisor for 999, so she helps the ambulance service as a midwife. Lots of research, education, charity. You can work in sexual health, abortion care as well. Some of our midwives will go off and do that, and neonatal care. So some of our midwives become neonatal intensive care specialists as well. And the next bit I'm going to talk about is kind of the changes that is happening in midwifery. And that's, here we are. Yeah, so the main, I've picked 4 that I think are quite predominant. There are loads of different issues in midwifery, but I think these are the 4 that I've noticed have become the predominant ones at the moment. So Better Birth, this is a big document that came out several years ago, and it's kind of trying to improve neonatal and maternal outcomes. So they found that actually through continuity, like I was saying, so looking after women by a midwife or a group of midwives through their pregnancy, through their labour and postnatally, has been found to have much better outcomes. So that's a big push across the UK. One that's been in the media a lot at the moment and is being heavily reported is that our racial health inequalities that is across maternity in particular. We've found that there is, I think, a 4-fold increase of risk of death for those who are Black and African Caribbean, which is incredibly sad. So that will be a really important bit to kind of cover as well. I put on here a bit about increasing complexity, so having more specialist midwives to develop high risk care. And our big change as well is that reducing stillbirth and neonatal death, so we're continuing to do that as well. I think that would be, I think I've wrapped it up there. If you've got any questions, thank you for listening, and if you've got any further questions, there's my email address, and I popped a little further reading on there as well for anyone who is further interested. Thanks.
Thank you so much. That was really interesting, even as a medical student. And now we have Elzbie, who is a physiotherapist, and she'll talk about her career. But thank you again so much, Sian.
Hi, everybody. Thank you for having me speak today. And thanks to everybody turning up, spending your Saturday afternoon listening to us. I think it's a really brilliant thing that we're doing. So I hope you enjoy. So I'm Elzbie, and next slide. Thank you. Thanks. So just today, we're going to cover a little bit about what a career in physiotherapy might look like. And I'm going to tell you a little bit about my own experience, and then I'll tell you a little bit about kind of entry and things to consider, and probably some things that I would have wanted to know when I was first applying. So I just wanted to pose a rhetorical question to you first. Just have a look at the pictures on the left and right and have a think. When you think of physiotherapy, what is the first thing that you think a physiotherapist does more of? For example, the picture on the left, listening to a chest of a neonate, or on the right, massaging someone's back. And just having thought about that for a second, I think most people probably will answer, we probably do the latter more. And actually that's a very common misconception that I think followed physiotherapy around because of its history in manual therapy and massage. And actually since I qualified in 2018, I hadn't done a single massage on a single patient, and it's actually not an evidence-based intervention. And we do a lot more of the former. So I think physiotherapy's roles are really diverse, and it has evolved over the last 10 years, 20 years, so much, and it's changing so rapidly today. And I'm looking forward to telling you a little bit about how it has changed. So what does physiotherapy mean to me? And, what is it as a profession? It's very diverse, and we see a lot of patients from neonates to centenarians. We are involved in diagnosis, screening, rehabilitation, obviously. You might have seen a physio for an injury rehabilitation program. We prescribe exercise in hospitals and the community. You might see us in the gym as well. But actually most physiotherapists work in NHS hospitals in this country and are widely involved in research, management of patients on wards, acute settings and outpatient settings. And really, if you were to go into any hospital ward, you would probably find a physio on that ward. I think it takes a lot of emotional resilience to be able to become a physiotherapist and stay a physiotherapist, because you're dealing with people on such a close basis, sometimes with one person for hours on end, for weeks and months, and sometimes even years if you get involved in certain areas of physio like stroke rehabilitation. And it's a hugely evolving and dynamic profession, and I'll tell you a little bit about the specialties which you can choose to become as a physiotherapist as well. Thank you. Next slide. So I think COVID-19 has probably showed us quite a bit about how physiotherapists work and how our roles are capable of changing at a time of need. That's me on the right. When I was redeployed onto A&E at the beginning of the COVID outbreak, I was very nervous. I had been working in outpatients at that time, and I was relocated to a hotel, working 60 to 70-hour weeks, lots of on-call nights and evenings, 7-day working, like on the weekends, really on front care services like respiratory, acute stroke, orthopedic and trauma services, trying to see and assess as part of a multidisciplinary team anybody who was coming through our doors to try and minimize the impact of kind of people really struggling to get out of hospital throughout the COVID crisis. And I think we've learned so many new skills throughout the COVID pandemic, and physiotherapists were working frontline alongside everybody else throughout that time. Thank you. So I've just written down some specialties that are some more well-known, some a little less known, which you can choose to specialize in if you do choose to go down the pathway of studying physiotherapy. And I'll tell you a little bit about that kind of development pathway later on. But I think what we're most well known for is musculoskeletal care, which is taking care of patients with acute and chronic injuries in an outpatient setting, usually in hospital, but you can see us working in private practices as well, or as independent physiotherapists in the community. But really, musculoskeletal care is really diverse, and there's emerging specialties like chronic pain management, rheumatology specialists and consultants, and some hand therapists emerging as well. There's also neurology, respiratory, elderly care, trauma and orthopedics, pediatrics, A&E and critical care, women's and men's health, palliative care, and the probably most well-known sports physiotherapy, which only makes up a tiny part of physio. And what I wanted to tell you about next, thank you, is a little bit about what actually entry looks like and what you might expect from a degree in physiotherapy. So the physiotherapy entry requirements have really changed over the last few years. And depending on where you want to go in the country, they will be looking for different things. So I studied at the University of Brighton, which typically has lower requirements for academic grades, but more requirements for the type of experience that they're looking that you acquired during your time as a student. Whereas a lot of the London universities like King's College London here at the bottom left that I've included want similar grades or sometimes higher grades, especially if you are an international applicant, but are a little bit more lax on the type of experience that they're happy to accept, depending on what you've been able to obtain throughout your application process. So I've written down a few helpful things, hopefully helpful things, such as experiences that most universities are looking for. You know, it doesn't have to be hospital-based experience. You can, you know, if you can prove that you've had a caring role or working with people in any type of role, such as a pharmacy or even a library, and really talk about the experience that you've gotten from it, then I think you will be flying colors in the interview. And it really doesn't have to be hospital-based experience. However, if you do manage to shadow a physiotherapist, I think that's really helpful because you get to see the ins and outs of their daily working life. And because it's so varied, it can be really difficult to decide, you know, is this the right profession for me? But the more experience you get, the better, but it's not an absolute must. There is no entrance exam for entry into physio school, but you do have to interview, as I mentioned, and interviews are typically one-to-one interviews or multiple mini interview stations. And that's been changing over the last few years. And especially over COVID, everything's been done online. So I appreciate getting work experience is really difficult right now, but there's been an emergence of virtual clinics, which have been giving students access some of the time to just watch how consultations occur for you to get an inside look. So this is what training throughout the whole profession looks like. Most courses are 3 years long as an undergraduate degree. First year is usually theory-based, and you undertake modules such as physiology, pathophysiology, and a lot of anatomy and exercise prescription. In second and third year, you do a lot of clinical placements, usually in hospitals or the community. Some people go on to do specialist placements, like in psychiatry or women's health or pediatrics, really depending on whatever your interests are. So you can tailor your learning experience based on what your goals are and what your interests, where your interests lie. If you already have a previous degree and you want to re-qualify, you are able to do a 2-year master's accelerated physio degree. This is called a pre-reg physiotherapy degree, and it's basically the 3-year degree squashed into 2 years, so it's really tricky. It's quite challenging, but a lot of people have had good feedback about it and said that even though it's really challenging, it's exceptionally interesting and it pushes you to be a better clinician. But even the 3-year degree, I think is really quite tough work, but it's a really brilliant degree, and it's a good balance between academia and clinical placements. You get to do quite a lot when you're a student on the wards with supervision and really learn with your hands. So if you're a person who likes to work and get your hands onto things and really be in the middle of the multidisciplinary team, then this is a really good degree and a really good profession for you. Most people who qualify through either route then tend to go on to be junior physiotherapists, which are basically a band 5 position, usually in the NHS, rotating through different clinical specialties of different lengths. So some trusts will do 2 to 4 month rotations in something, let's say, care of the elderly and then orthopedics. And some trusts will do longer training posts with more opportunities to really develop your leadership on the ward and progress onto a band 6 position, which is where you get more responsibility. You might take on students. You might start teaching people on the wards how to kind of do physiotherapy. You might become a mentor on the wards, and you might choose to specialize in something. However, if you don't want to specialize, if you want to continue rotating or you want to stay quite general, you can be a rotational band 6 senior physiotherapist and just continue working through different wards in different specialties for as long as you like. At that point, you can choose to become a band 7, which is a quite senior physiotherapist. Usually they're leading a team in a specific specialty. And they have responsibilities of a kind of more managerial role. You can choose to work in private hospitals or clinics straight out after graduating or after doing your band 5 rotations or band 6 rotations. You can create your own business if you want to be working as a private physiotherapist independently. Or you can choose to become a locum physiotherapist, which is when you move around to wherever there's a post that needs to be filled and you get to experience lots of different specialties and work with different teams. Next slide, please. So I won't read it all out. I won't read all of this out, but this is a very brief overview of the kind of specialties that I've worked in. And this is over a little bit over 2-year period. So when I was first qualified as a junior physio. And some of these places I worked on as a qualified physio, and some of them I got experience as a physiotherapy student. So as you can see, there's a huge diversity in the things that you get to experience. And when you're working in all of these specialties, you not only learn the physiotherapy side of things, but you also get to know how the hospital works. You work closely with occupational therapists, speech and language therapists, midwives if you are in obstetrics and gynecology. You work with doctors every single day. You know, nursing staff and physiotherapy staff are completely interlinked, and you're frequently getting nurses to help you with your physiotherapy for patients. So you have to be a team player wherever you go. And and just know that you're never working in isolation, because when you're looking after a patient who needs physiotherapeutic input, they need more than one thing. They don't just need an exercise prescription. They need support. They need emotional care. They need physical support, and they need you to be the kind of guiding figure throughout their journey in hospital. So, for example, when I was working in musculoskeletal outpatients, I was seeing 15 to 20 patients a day, a lot of them chronic pain patients who needed holistic management, advice, triage, and referrals back to GPs, or straight to A&E, or orthopedic referrals. So you were always working as part of a team, and wherever you go, there's so much to learn. And I think that's why what I enjoyed about physiotherapy the most was the learning is never ending, and I really like learning like that. So I found it really exciting to switch from one specialty to the other. But some people I know went straight from kind of universities to specializing in one thing because they knew straight away they wanted to do something, whereas I wanted to experience as much as possible. So I kept my options quite open. Next slide, please. Oh, sorry, that's come up quite small. I hope you can see that. These are some examples of patient vignettes. They're not real patients. I just wanted to give you a taster of the types of people that you might be seeing, the types of people that might be coming to you if you were to become a physiotherapist, and some of the things that you might be able to help them with. So I won't go through all of them, but I just wanted to pick out a few poignant cases. So let's just look at the first one. So a 29-year-old male, if he was to come with new onset urinary incontinence, which is when you can't control the flow of urine, and he had an inability to sustain an erection, and new onset low back pain. So this might not seem like a physiotherapeutic problem to you, but we see these patients a lot, and actually, unfortunately, they get sent to physiotherapy quite a lot because of back pain. But actually, this is a medical emergency that we as physios have gotten very good at picking up: compression of the spinal cord. And if I were to see this patient in my outpatient clinic, I would do a thorough assessment after taking a thorough history, liaise with our seniors, and then usually triage straight to A&E through orthopedics or neuro on call, and get them into emergency surgery. Another case just underneath that one about this 67-year-old female. Somebody like this might come to you in a hospital, might be referred to you after having sustained a really quite traumatic incident, like a road traffic accident, having fractured several bones. You know, they might be quite frail, they might have other health conditions, and you're the first person to really put them in the position where they have to face the prospect of potentially standing up in a lot of pain, using broken limbs, learning how to walk with new equipment, and usually we're the people who are often not liked at first because we make patients go through really quite unpleasant processes, especially if they're after, you know, having sustained traumatic injuries. But in the end, we do end up close friends, I think, because we spend so much time together. So we usually rehabilitate patients on wards, and then might see them in our outpatient department months later once they've started to heal up a little bit, and then sometimes even go out into the community and see them at home to see how they're getting on. So for this woman, we would see her in a hospital, make sure that she's gotten her pain relief, and speak to the multidisciplinary team and see whether she's ready to start walking or potentially just getting out of bed, and really spend that time with her and invest in getting her strength back so that she could go on to do the things that she needs and wants to do. Another case would be, for example, a 26-week-old premature baby. You might get called in the nighttime to see a baby who was in respiratory distress and on ventilation in the acute or intensive neonatal care unit. So for this baby, we would look at their recent radiological imaging, speak to the nurse who has potentially called us in. If there's a need to call the doctor, if the problem is more serious, then we would make sure that the doctor is called out. And if not, if we can manage the situation, then we would provide respiratory care, you know, as an emergency situation. But in a non-emergency situation, seeing this child, we would assess their development, make sure that the ventilator is still working okay, that the baby's taking good breaths, and that the baby's maintaining good strength while they remain on ventilation. And then after they come off of ventilation, we would make sure that they're still breathing well, not retaining sputum, and liaise with the parents to show them maybe how to do respiratory care for their child once they're back home. So I hope that you see that there's a real diversity in the type of patients that you might see as a physiotherapist, and that seeing sports injuries or sort of providing manual therapy is a very, very tiny part of physiotherapy. And actually we utilize many more skills to really help our patients manage pain and regain skills and function, and also understand their conditions and understand and manage their conditions better themselves. Next slide, please. So yeah, so I've put this picture up because I just wanted to illustrate the fact that you need a lot of tools if you're going to become a physiotherapist, and a lot of the tools are not just your hands. We use the gift of the gab a lot, and taking an accurate history can sometimes take hours in an outpatient department, because we treat many people with chronic pain conditions, and chronic pain conditions are incredibly complex, and people have stories that they need to tell about their lives. And physiotherapists are often on the receiving end of those, which is a very privileged and lucky position to be in. So we get to know our patients well, and we are very, very lucky to spend really extended periods of time with our patients, which means we're usually the person they're asking big questions to, sometimes questions that we cannot answer, but we can definitely help and support our patients and guide them through whatever health condition that it is they're managing. Next slide, please. I've just put up a few things about physiotherapy, about how it is progressing and the new types of roles that have been emerging over the past decade. I think this is really exciting. I mentioned pain management. We are becoming the lead clinicians in pain management alongside doctors, nurses, psychotherapists, psychologists, occupational therapists, and other staff. But because we have such a pivotal role in exercise prescription and management of pain, frequently patients go to physiotherapists for chronic pain conditions. Also, we've increased the amount of cognitive therapies and acceptance and commitment therapy counseling that we're using in our consultations. There are more first contact practitioner roles, independent prescribers, academics, and consultants in the profession. So there's not just one way to be a physiotherapist. It's such a diverse profession, and I hope that this presentation has kind of illustrated that to you. Next slide. I'm happy to take any questions at the end, and also by email. Thank you.
Thank you so much, Elzbie. It's really great to see the variety of experiences that you guys can get. It looks like a really great opportunity, and I remember how much medical students were supported by physiotherapists on placements. So I'm looking forward to that when I start placement again. And next up we have Michaela, who was trained as a nurse. So she will be telling us all about her profession and how you can get involved in the field. So again, welcome and thank you so much for your time.
Thank you for having me, and it's been lovely to hear about the different professions in healthcare already so far. It's really interesting. Obviously, I only see a certain side of things working where I do and being trained as a nurse, and it's lovely to hear the different ways to become, say, a physiotherapist, or how to get into midwifery. It's something that maybe, unless you're interested in doing that, you wouldn't necessarily get the chance to hear. So hopefully it means I can take something away, and if anyone ever says that they're interested in one of those things, I can share the knowledge I've got today from this with them. So yes, could we just pop onto that's it, thank you. So my name's Michaela. This is a very cheesy little presentation section I have prepared. So I am a critical care nurse, and I've named this section of the presentation "When a Career and a Passion Come Together," because yes, whilst it sounds cheesy, it is something that you might find a lot if you talk to a lot of nurses, that they'll start off with an enthusiasm for something and then it just sort of rolls on from there. And nursing is a lot of healthcare professions, but I think nursing is not necessarily just a job, it's part of who you are. And I think midwifery, physiotherapy, they're all very similar in the sense that you will always be a person. Even if you go on and change your career, you will always be someone who has the skills you've gained from being in those professions. So across this section of the presentation, I'm going to talk to you a little bit about nursing, what we do, where you can work, how you can get into nursing, some common misconceptions, and the frequently asked questions that I get when people ask me about how I became a nurse or why I became a nurse. So I'm just going to start off with the next slide. So what are nurses? Nursing is a profession within healthcare focused on the care of individuals, families and communities so they may attain, maintain or recover optimal health and quality of life. And nurses comprise the largest component of most healthcare environments. Like Sian was saying, midwifery, for example, is quite a female-dominated profession, but that is changing over the years. That's the same with nursing. We have quite a heavily female-dominated population of nurses. However, again, similarly to midwifery and the other professions, this balance is changing, and it is lovely to see, because obviously when you think about it, you're going to come across patients in hospitals that are male, female or non-binary, may not identify as anything, may be transgender or any of the different things that people may choose to identify as or not, as the case may be. And they might not feel comfortable, for example, if there's only female nurses around, they might prefer if there was a male person there to look after them. So we're seeing a massive increase in males in the nursing profession, which is lovely to see. It means that we can feel like the population we're looking after is getting what they need from us as nurses. And we're seeing particularly a big increase in male nurses coming from other countries, which is lovely. In a lot of countries, I know not necessarily thought of in the UK at the moment, hopefully that'll change one day, it's one of the most revered professions you can go into to be a nurse. It's a very high privilege to be a nurse in a lot of countries. So we have a lot of nurses in the hospitals that I've worked in who've come over from, say, Italy or Spain or the Philippines, where there's a lot of males in there, and it's lovely to have that bit of variety and diversity. So nurses are involved in every aspect of life and death. We happen to be a massive part of a person's life journey. There's often a thrown about phrase in university, if you're studying a nursing degree, is that you're there from the cradle to the grave, and this is possibly true. You have nurses who look after pediatrics, nurses who look after every other age group, and then the specialties within that. A very famous nurse that most people will have heard of, Florence Nightingale, the Lady with the Lamp, sort of the pioneer of modern nursing. And she said, I think I'm possibly misquoting, I do apologise if I am, it'll take about 150 years for me to see the kind of nursing that I envision. I'm hoping, because the 150 years came up to 2020, I'm hoping she wasn't planning on coronavirus being a thing now. But I think she was more thinking about the change in the profession, the shift in what we can do and where we're looking to go in. So if we just pop to the next slide, please. Thank you. So all registered nurses must choose from one of the 4 specialisms when choosing a nursing degree and undertaking it. We have adult, child, mental health and learning disability nurses. And I've abbreviated mental health and learning disabilities there just in the centre. That might happen throughout the PowerPoint, so I do apologise if you're sort of confused as to what the letters mean. It is possible to change from one branch to another, during the course of your degree, or after you've graduated. It could be years down the line into your career. So just because you pick to start off with one, it doesn't mean that defines your career for the rest of your life. And that's something that attracted me to nursing in the first place, that it's such a diverse career. You can have multiple careers within your scope of being a nurse. I chose to study adult nursing because I felt that I was more drawn to that sort of population. I didn't think that I would be a particularly good child nurse, and I didn't think that I would be as good specializing in just the mental health side of things or just the learning disability side of things, which of course I then found out on my nursing degree. There's no such thing as being one specific specialty in nursing. Whilst we divide into 4 branches, they cross over all the time, and it is part of our learning to be able to understand each different aspect of nursing, because when you meet someone, they're not just, you know, a 10-year-old girl or a 50-year-old man. They are a person who has thoughts, who has different maybe abilities to each other, and you know, you're never going to come across one person who fits into the adult, the child, the mental health, or the learning disability category. They will all interlink. So they can work in a variety of different places. I work in an intensive care unit, so I work in an acute hospital setting, but you can work in the community, you can work in specialist places. And I think on the next slide, I've just got some examples of where people can work. So the photograph with the sort of glass looking fish bowls, I'm going to describe them as, that is the intensive care unit that I work on when it was first opened. It was designed with infection control in mind, and it was quite useful in the coronavirus pandemic. So that's just a sort of brief overview of where people can work. So I've said, you know, you can be a medical nurse, a surgical nurse, you can work in critical care, perioperative care, so you can work in theatres, recovery, anaesthetics. You can work in community settings such as in care homes or district nursing, GP surgeries, clinics. You can go on into research and teaching, or even if you're not thinking about sort of the conventional places you could work, a lot of people don't know that nurses work in prisons. And you can work in the NHS, you can work in private settings, you can work in the armed forces as a nurse officer, for example, in the Navy perhaps, or in the Army, or you can work for the government. So there's a lot of agencies who work for the government deciding things to do with disability and benefits, and there's often nursing teams. I think it was mentioned before that 999 and 111 call handlers often have triage teams that are healthcare professionals, so often paramedics and nurses and doctors might work there. So just a little bit about where I work. I work in an intensive care unit, as I mentioned. So I work alongside doctors, other nurses, physios, specialist nurses, a rehabilitation team, speech and language therapists, dietitians, research nurses, and a never-ending spectrum of people to be able to deliver the best possible care that we can to the often sickest patients in the hospital. And often our patients might be what we call level 3 patients, where they're requiring advanced respiratory support or some basic respiratory support with other organ failure going on. So we might have multiple organ failures or sort of cardiac arrests that come to us, or people who've been on the wards and have suddenly become very unwell. So often we have to be able to look after someone who is sedated and on a ventilator, for example, and we have to be able to make sure that not only do we provide high quality nursing care for a medical reason, but that also we can continue to look after their mental health, and we can advocate for that patient when they are sedated, and that is a large part of our job. If we just pop onto the next slide there. So common misconceptions of nurses. I popped on some memes on there because I think sometimes that is a good way to sum up what people think nurses do. So often people ask me why I became a nurse, because I did a degree before I did my nursing degree, and people often thought, why did I choose to do something completely away from the first degree which I did, which was politics and international relations. Often when I say that and then say, oh, I'm a nurse, they look at me like I have 6 heads, as if that was an odd decision to make. So the most common misconceptions I've had to sort of verbalized to me about nursing is, you're doctor helpers. I mean, we do help doctors, like doctors help us, but that's not what our job is. We just undertake a slightly different side of medical care. Doctors might make a decision about something, nurses might carry out that decision, for example. Another one was not smart enough to be a doctor. It takes a lot of intelligence and a lot of common sense and a lot of care, compassion, and various other skills to be anything in healthcare, as I'm sure those here today will know and understand. And it has absolutely nothing to do with your ability if you choose to go down one route, say nursing instead of medicine, or physiotherapy or midwifery. A lot of people have said, oh, is working in intensive care where you have one level 3 patient, for example, in ideal circumstances, is it a glamorous job? No. Nursing, sadly, is not what you would class as a glamorous job. There's a lot of stereotypes about nurses with the pretty little hats and being all females, and it's lovely and all wonderful. That's not what it's like. As you can see on the picture on the left, there's what my friends think I do and what society thinks I do, which is sort of dirty jobs. So yeah, there is an aspect to it where you're carrying out patient care that is to do with hygiene or bowel movements or urine output, and that's not exactly what you would class as glamorous, but it's part of looking after someone and it's part of the job. And my favorite one was, I think a while ago, there was an American, I think Congress person perhaps, or councillor, who said nurses just sit around and play cards all day. I would love to do that as a job. I'm sure it would be wonderful, but no, we don't. We do a lot of different things. We basically do the last part of the picture on the left, the what I really do, which is multitasking and doing lots of different things. Because like I said before, when you're looking after someone, you might be treating a medical problem, but that's not the only thing you treat. You treat a person. You have to look at their sort of needs on a scale of what is the medical problem, but then you look at sort of, are they in any pain? Do they need help with eating and drinking? Do they need help with being able to go to the toilet? Do they need help with moving? And then arranging referrals based on that and helping them out from a nursing point of view. Sometimes it's, can they communicate well? If they can't, how can we sort of help them with that? And a few comments and questions that were often thrown to me about nursing is, well, am I too old to start nursing? Coming from someone who was, I think, about 22 years old. And I said, well, no. I was 21 when I started my nursing degree, which is still quite young. People who were in my class were in their 30s, 40s and 50s. And there is absolutely no age limit on any career in healthcare. You might think, oh, it's quite a few years to train and then you have to get into specialties and this, that and the other. Honestly, if you're thinking about doing it at any age, if anyone's ever talks to you about doing it at any age, please just encourage them to follow their heart and go for it and do their research. The kind of shifts that people think nurses work, we work every shift possible. We do sort of 9 to 5 type hours, Monday to Friday in some settings. We do 12.5-hour shifts, so we do night shifts. We do shorter shifts, but we do Christmas working, we do bank holiday working, we work the weekends, we work our own birthdays. It's just, you know, we work every day because hospitals are open 24/7, which confused my mother a lot when she was like, you're at work on Monday, but it's a bank holiday, as if the hospitals were just going to close, which would have been lovely, as it was lovely weather, but you know, this isn't how it works. If we just pop onto the next slide, I've got some skills that you learn in nursing that I thought might be interesting to mention, just sort of gives people an overview of what we might actually do. So the pictures I've included, there's one in the left, which is someone in an intensive care unit setting up various different machines. There's a dialysis machine in there, there's fluid replacement machines, there's a ventilator. So we learn how to set up all those machines and use them and make sure that the patient's getting the correct medical care. The top picture is cannulation. We can learn to cannulate and take people's bloods. The picture sort of in the middle there is some basic and intermediate life support. So we, do CPR skills, using a defibrillator, using medications that will help somebody from a cardiac arrest. The picture on the right at the top is a doctor's handwriting. You will learn to be able to read any kind of awful handwriting, and this will really help you at some point when you come across children who've written you a card, and most people would look at it and think, oh, I'm not too sure what this is. You can translate it perfectly. It's a skill that seems like it's nothing, but it is one of the best skills you will ever come across because it will help you throughout life. Another sort of different set of skills that we have can be to do with medication administration. So not only do we give medications, often we have to work out the dose based on the order. So doctors might order that a dose can be given, say they want 10 milligrams of something given, and all we have is like 1 milligram tablets. So we have to be able to translate across into what we have and how we can administer the correct dose based on the formula of the drug that we have is. We give blood transfusions, we give personal care to do with hygiene, elimination, eating, drinking. We can put someone on dialysis. We can be able to care for all of their spiritual needs, mental health needs if possible. And we learn a lot about decision making, reflection and leadership skills in nursing. If we just pop onto the next page. I mentioned before, and it's mentioned by the other ladies today so far, that nursing is a very diverse career, just like midwifery, just like physiotherapy. You can go on from a band 5 nurse, which is what I am, a band 5 staff nurse at the moment, to being a nurse consultant. You could be a specialist nurse in, say, cardiology or in diabetes or in renal therapy. You can become higher bands within your own area. You could become band 6 or 7, which is, you know, often known as a sister or a charge nurse. You can go up to become a matron. You could be a nurse practitioner, which means you have more advanced clinical skills, and you can go on to do your prescribing skills. You can do supplementary courses and do things like aesthetic nursing. So you can do your lip fillers, you can do different things like Botox and such. You can go into health visiting and more community roles, or you can go into research and teaching. Or you can go into midwifery, or you could become a physiotherapist, or you could go into medicine. It's a very diverse career that gives you a good set of skills that you could adapt into anything. And they're just some of the careers you can go into. That's not a definitive list. I just thought if I started listing them, we'd be on for a good few hours at least. So I'll spare you that, and that you can do some more research on that yourselves if you'd like to. On the next slide. There's a couple of pictures. I apologize that it is shameless selfies and such that I am in, but the changing face of nursing because of COVID-19, we found that it became difficult to be able to demonstrate certain aspects of nursing that we would normally be able to put across easily whilst having to make adaptations for COVID. So obviously we had to start wearing masks and PPE for safety, to protect ourselves and our patients, to be able to protect the general public and our families back at home if we were still living with families. But it became hard to be able to communicate with people. So a lot of people lip read, and adaptations had to be made to be able to help them understand people through masks. A lot of people find they can't hear us as well, even if they've got sort of no pre-existing conditions that might impair that sense. And we found that constantly being in a room, say for example the picture on the left is a picture of me at work with one of my colleagues, and that's how we would enter a room with a COVID patient in a full PPE with, you know, an FFP3 mask, a visor, hats, big gowns, a couple of pairs of gloves and shoe covers, and going in to look after someone who is very unwell and very scared if they were on the CPAP high oxygen that we had. To be able to talk to them and try and reassure them, often parts of nursing would be holding someone's hand or giving them a hug of reassurance. And COVID really impaired how we were able to do that. And whilst you could still hold someone's hand, it wasn't the same as they were feeling a couple of layers of gloves, and it sort of felt very impersonal. So we came up with little ways to try and still make people feel cared for and loved. One of the best ones that our unit came up with was we would get someone to draw either our names and some like sort of, we'd get a picture of us to put on, whether it be a nice selfie or something, so that people could see what we look like. Or we had a gentleman who was from Scotland who had been talking to one of the nurses about missing being home, but having not been able to go back up and visit the rest of his family for a while because of COVID. So we had some white gowns that day, and we drew little Scottish flags across them and attempted to draw a few little stereotypical Scottish things, and did this outside the room and danced to try and make them laugh before we went in to sort of see how we could help them. And it did it helped us to remind people that, you know, nursing is still a profession that we can show care in, but it was very difficult at first to be able to make these adaptations. Another change that happened because of COVID was we had this odd sort of staffing issue, which we were already a chronically understaffed area. You'll hear it in the news all of the time that there's not enough nurses. We're trying to train more nurses, but there's not enough nurses. So staffing levels are difficult. This got even worse with COVID because staff sickness was going up. People were leaving the profession because they weren't able to cope with it. And it was a very difficult time for a lot of people. However, a beautiful thing that we saw come out of the COVID pandemic starting was there was a massive increase in applications for nursing, whether it was somebody who was at the university, like ready to start university age, who thought they were inspired by what they were seeing and how they were hearing about how we were coping with what we were doing, that decided to go into nursing, or whether it's people who had been furloughed that decided they wanted to retrain. And it was really beautiful to see the wave of enthusiasm for a career that isn't just a career, it's a way of life, it's a vocation that nurses have. I mean, you have to care a lot about your job in healthcare to stick with your job in healthcare, because it can be difficult at times. But it was nice seeing the public appreciate that and want to be involved in that. And I'm always happy to hear people talk about their careers in healthcare and how passionate they are about people, because it's lovely to hear. And it was lovely to see those increase in applications. And the picture in the middle is my cohort. I was a 1709 student, so I started in September 2017, so I was due to finish September 2020, and April 2020 came along and we were asked to opt in as a band 4 nurse, which was you can do a lot of things that band 5 qualified nurses can do, but there's certain limitations to your practice. So you couldn't give intravenous medication, for example, but you could give normal medication with your PIN. And they asked the 1709 cohort to step up and become band 4s. And this was optional, you didn't have to. But my group decided that we were all going to opt in to support the NHS, which meant that we lost our supernumerary status, which is something that as student nurses we were supposed to have. It meant that we're not in the staff numbers, so we should get learning opportunities. Doesn't always happen as well as it sounds on paper, but in theory we should always be given the best learning opportunity on a placement possible. So we were able to get really hands-on with this, and we were paid a wage, which wasn't the be-all and end-all, but it was quite nice to be able to feel like we were able to save up some money for qualifying, to be able to afford, some people wanted to buy a house, some people want to buy a car, and it was lovely to be able to start planning for the future whilst also helping the NHS. I was told in my first year of nursing by our head of the department that the hands are the tools of a nurse's trade, and what he meant by that was we will hold hands, we will administer things with our hands, we do a lot with our hands, even I talk a lot with my hands to be able to communicate. And so he said that it's important that we make sure that we are very open with our body language to people when we're communicating with them. And this was something that we had to emphasize with COVID, I think, and it's something that I think going on, if we have to keep up with surgical masks, for instance, in hospitals, which I think might be quite likely, it's something that it's going to change the way that we communicate with people and the way that services are run. So COVID has done a lot to change nursing into sort of maybe not quite what Florence Nightingale had hoped for it, but perhaps, you never know. I can't exactly ask her, which is a shame. Could we just pop onto the next slide there, please? So this was my journey into nursing, and I popped in the bit about NHS superheroes because a lot of children were writing to the intensive care unit that I work at calling us superheroes, and I thought I'm going to pop it into the slide because we don't see ourselves as superheroes, people who work in the NHS or in private who work in healthcare. We aren't superheroes, we're just people, and we sort of just do our jobs as normal people do. But it was lovely for people to sort of recognise that we stepped up at a difficult time, just like thousands and millions of key workers across the country and across other countries did. So it was just a little shout out to everyone to say thank you for all of your help and support. So my unconventional route into nursing looks a little bit like that graph there. Instead of going from A to B, I took a lot of detours. I started off doing my A-levels. I can't remember now, it was quite a few years ago. I did history, politics and maths. And I went off and studied a politics and international relations degree. And I'm not sure what I thought I was going to do with that, but I probably had a plan in mind. And I think I was about halfway into my first year and I started to volunteer with St. John Ambulance with their university student volunteers. And as I was doing that, I was going out to events and providing first aid cover for the general public. We went to some high profile events, and as I was sort of learning new skills in patient care, I thought, oh, actually, I really enjoy this. And I'm enjoying getting to talk to people and meet new people all the time, because you can hear a lot of fascinating stories from people and learn new things all the time. And whilst I was doing that, I looked into the different healthcare professions, and I worked alongside doctors, nurses and paramedics. And I sort of fancied the idea of all three because I liked little aspects of each. When I was talking to one of the nurses I was working with, and she explained how diverse nursing was, how you could have a career within a career within a career, and you can change direction and you can learn new things and you never stop learning, but that it was focused on patient care. I realized that the parts that I was enjoying about my volunteering experience were the patient care side of things, and was just being able to help people and feel like I'd done something that had helped someone. And nursing suddenly became the thing that I knew I needed to do. And before that point, I didn't realize that it was a viable option in healthcare. Nobody had sort of ever explained to me that instead of just, medicine or going to be a teacher, there was the option for nursing or midwifery. And I just sort of realized something clicked and it felt like it was right. So I opted to do and applied to do my nursing degree, which was a 3-year undergraduate degree. And I'm going to discuss a little bit on subsequent slides, sort of what we might different routes into nursing. And I finished my degree in September, but I opted in as band 4 last April. Did my management placement, which was an extended long placement. Qualified in September and started in intensive care, and have been there ever since doing my competencies. And I just thought I'd throw in like my experience, because it's not something, you don't have to do nursing or any other healthcare professional role one way. It's not just, as it was mentioned earlier, you don't just have to go straight into one thing or do it a certain way. It can be done in many different ways, and none of these ways make you any better or worse of a nurse. It's just your experience and how you got there, and your journey is important because you're involved in other people's journeys. So you can't just dismiss one type of journey. It's just because it's not for you doesn't mean it's not for someone else. I think the next slide, I've got a little bit of information about access to nursing courses. Yep. So the ways that you can become a nurse, you can do an access course at college, which some universities will ask for. Some might not necessarily consider it if you've done sort of your sciences and maths as A levels. So you can do a 3 years bachelor's degree. So they look for A levels. Each university is different. So you'll have to check on UCAS with what their requirements are, but most of the requirements for nursing tend to be at least 5 GCSEs, which happen to include English and maths and science if possible, and 2 A levels or equivalent. So when I was applying, I would finish my degree. So I went with my degree qualification level and the fact that I'd done a maths A level and had my GCSEs in maths, English and science. And that university was happy with that. Other universities might have asked me to do the access to nursing course at college to top up, which is, I think it's health and social care course, or would have asked if I'd done any NVQs or anything like that. A lot of universities will ask you to demonstrate the ability to show you're proficient in basic maths and English. So they might ask you to do a maths and English test. You'll need to do a health questionnaire and identify if you have any health needs that they might be able to help you with. And you'll have to have a disclosure and barring service, a DBS check. And you can also do this by doing a 2 years master's degree. So if you've already got a degree, that was an option. It was an option for me, but I chose to do the 3-year degree as I felt that my degree wasn't really something that I could build off for nursing too much. I know there's a lot of political skills in nursing, but I thought had I done maybe a science degree or another healthcare degree, it might have built a foundation for me to work from. So I personally felt that the bachelor's degree was right for me at the time, and I stand by that decision today. But I know people who did the 2 years degree, and it was the best decision for them, so it worked really well. And again, neither of us is better or worse off for having done that. It's just what's appropriate for us and what our skill levels are. And I know that a lot of trusts will let people work in the healthcare assistant role and allow them to go to college and uni alongside this and help promote them into the nurse associate role, which takes you to a band 4 nurse, which you can top up to a band 5 with. This is sort of more apprentice-based training and is very valuable. You get very hands-on. I think my university structured their year where you would have 3 months at uni, and then you would have 6 months at placement, and you do sort of coursework and exams within that time period, and you would have maybe a little holiday and a study period, and then you'd do some more placement, and then you would have a couple of weeks at uni to round off that year before you had a small holiday and then restarted the so many months at uni and then placement. I know other universities have done different, and I know that the structure of the course is changing. So it'll be like a couple of days at uni a week, a couple of days at placement. Again, it's just dependent on the trust and the university that you're at. But at the end of all of the degrees, the different routes, you can register with the Nursing and Midwifery Council, the NMC, who's the regulatory body, and that's where you'll get your PIN number from, and that's who you sort of have to practice in the keeping with the code of the NMC, as well as within your own skill level. So the degree itself, as I've explained, was the way my university structured it was so many months at uni. And the modules that we did, just to touch on that, we did anatomy and physiology, but we did a lot of focus on public health and ethics and clinical skills and research, which is quite interesting because I would have thought it would have been more hands-on with bigger sections of anatomy and physiology, but a lot of it was to do with public health and how if you can find ways to educate people with health information, how you can help them to empower themselves to take control of their own health issue or their own disability, and how you can help them take control of that, or how you can help people avoid getting to a point of an illness by sort of giving them advice on how to avoid or take steps to sort of improve their lifestyle, for example. And I wasn't sure at first how this was relevant until I went on placement and I was able to help educate somebody with foods that they could eat that were suitable for them as a diabetic, and how explain to them a little bit about how their insulin worked and the different types of insulin that they had, so that they could understand it a little bit more, so they knew why they were having to make that decision. And I found that being able to do that really helped them sort of connect with you as a student nurse, because they were sort of unsure as to why they were being told that they shouldn't eat certain things because that's not fair to them and that's what they like to eat. But when you sort of took the time to sit with them and explain why this is the case, they were more likely, in my experience personally, to sort of understand and want to make that change for themselves, because they felt more in control of themselves rather than just being told by a doctor, oh, you can't eat this, you can't eat that. They were able to think, well, what can I do instead? What can I change about it? And giving them that power to make the decision for themselves was something that they appreciated. And I know that if I was a patient and somebody sort of wanted me to be as involved in my care as possible, that to me would say that that person's good at their job, because I know me best, and if I know that they're professionals and that they want to help me, but at the end of the day, it's me and my life, so I should be the center of my care. And when nurses and doctors and other healthcare professionals are able to do this, this is really good. This is them doing their job really well. So that was the focus of the degree at the university that I went to, and it was really useful. But your clinical skills and everything you get taught along the way, and then you get to practice them on placement. And it was a very hands-on degree. I think I've only got a couple of more slides left, but the next one that I've got is people ask me what skills do I need to become a nurse, and to be honest, I've listed some skills that are useful, but you don't really need any pre-existing skills, because a lot of these things you probably would do without realizing it. Can you listen to people well? Can you communicate with them verbally, non-verbally? quite well. I mean, we probably do these things subconsciously. I've mentioned the 6 C's there, which are care, compassion, communication, commitment, competence, and confidence. These underpin nursing and the NHS in general. No one C is more important than the other. It's just how you place a value on them. But we probably all have a degree of care, compassion. We will communicate with people. We are committed to things. We turned up here today, for example, there's commitment. Competence in what we are talking about, how we undertake our role, and a confidence in ourselves and our abilities and what we are doing. Organisational skills are very useful for the university side of things, if nothing else. Teamwork, which most people will probably be very good at. It's very important, as we've mentioned today, we all work with each other. There's not just sort of set roles. We do sort of each other's jobs sometimes. We work together to find the best outcomes for people. And learning. I know it was mentioned before that you will learn something every day that's new, and you will keep learning, and that's what really attracted me to healthcare in general. That I love learning new things, and things change all the time. Policies change, new research comes out, new things develop. And I love the thought that you'll learn something every day. And one of my mentors, who's a couple of years off retirement age, said, you know, the day that you stop learning in healthcare, be it nursing, midwifery, or medicine, or anything else, is the day that you should probably quit the job. If you think you've learned it all, then that's when you've probably finished your career, and you should probably think about settling or moving on, because you should be learning new things each day. People that you come across are going to teach you things that you wouldn't have come across. And it's just, to me, I'm very passionate about learning and being able to learn things from people. So that's something that, you know, if you've got an interest in learning, you will do well in any healthcare career. And for example, even teaching, we get students from all different disciplines. So the other week, I was helping to look after a student paramedic in the intensive care unit, because they get a critical care placement with us. And in medicine and nursing, and I'm not sure for every sort of branch of healthcare professionals, but I'm sure it's the same. You get a sort of see one, do one, teach one kind of thing. So you'll see a skill being done, you'll be allowed to have a go at it, you'll practice that skill, and then you'll teach someone else how to do that skill where it's appropriate to do so. And I think it just sort of ties in really well with learning. So if you're happy to be able to teach other people, that's a big part of roles in healthcare. And it's something that if you're interested in, it means, I think, that healthcare is for you. So I think that's the last slide I've got, is the next one, which is just some more slightly cheesy quotes. But thank you, and I'm happy to answer any questions. My email address was on the first slide, so if you sort of think of things afterwards, I'm more than happy for you to email me. It might be that I am between night shifts at the moment, so I do apologise if I've talked a bit fast, or if not all the information was written on the PowerPoint itself. I don't like to bog things down with too many words. I like to try and verbalise. So you can get in contact with me, or you can send questions on the system that we have here at the end. But thank you very much for your time, everyone.
Thank you so much. We will now play this interview that I did 2 days ago with Georgia and Joana, who are 2 biomedical scientists, and they put together a little presentation as well as a Q&A regarding the subject. Shams, I think you're not playing the audio, so you might need to just reshare your screen, making sure you're sharing that.
Okay, wait. Is this playing?
Yeah. And many other events. We also have Georgia, who is a biomedical scientist. They both have a background in biomedical science, and they will tell us all about the opportunities that you can get by studying this degree. So thank you both so much for taking the time to join us today through this video, and please take it away.
Thank you, Anna. We're very happy to be here. So as Anna said, I'm just going to give you a very sort of general introduction to what biomedical sciences are and the sort of topics you could be studying if you choose to follow this career path. And then Georgia at the end will be talking specifically about her role in Public Health England, which is currently very relevant, of course. So very briefly, biomedical sciences really is science at the heart of healthcare. I think I've got a slide with some statistics at the end. So I think about 70% of diagnoses have influenced by biomedical scientists. So they are behind every single sample that you get taken when you go to the GP or anything like that. And sometimes the results are critical to inform treatment, to inform diagnosis, and so many other things. And everyone will use some sort of biomedical scientist service at some point in their life. So it's one of the broadest, so it's one of the broadest areas of modern science just because we cover so many different disciplines. So it's split more or less into 4 different sections. So you've got your infection sciences. So that is looking at study of microorganisms, which is a bit of what Georgia does. You've got bacteriology, which looks at bacteria specifically, and virology, which looks at viruses, so things like COVID-19. You then got your blood sciences, which is a very, very broad area, so includes things like chemistry, hematology, which is the study of blood, transfusion, that's blood donations, and immunology, which is your immune reactions. You then got your cell sciences, which is more about microscopic study of certain tissues. So this can be useful in things like cancer and sort of monitoring certain diseases, even during screening and not necessarily for diagnosis. And finally, you have genetics, which is obviously a very up-and-coming field, which instead of using our general typical wet lab procedures, tends to use a lot more computers and bioinformatics. So this is just to give you a flavor that it is a very broad area, and there is a lot of scope to do a lot of different things. And so biomedical scientists tend to work in the labs. So these might be labs from the NHS, so they may be private labs, or they can even be research labs. And as I said, so the work is essentially to diagnose, screen, monitor, and also do research in all sorts of body fluid samples. It's not just blood, it really is anything. And that's the statistic I was telling you about earlier. So it's estimated over 70% of diagnoses are based on laboratory test results, which require biomedical scientists to be there and process them and analyze them. And then the roles of a biomedical scientist can really range from many different things. Some people choose to go work in clinical labs, but then others might go into forensics or food safety or so many other things, teaching, research. There's just all sorts of avenues that you can really go down. To study biomedical science, you would need to do a biomedical science degree. And the place, oh, I'm really sorry, I thought I had a logo here. Give me just a sec. So if you just Google IBMS, you will see their website. So this is the Institute of Biomedical Science. Those are the guys that approve biomedical science degrees in the UK. So they'll have a list of all the degrees in the UK that are accredited by them, and those are usually the best degrees to go into the field because they are accredited, so you don't need to do any equivalencies, I think that's what they call it. So if you study a degree that's not accredited by them, you then have to go through a number of assessments to make sure your degree is of a good enough quality, whereas if it is an accredited degree, you can go straight into this career. So let me just go back to where we were. So to study biomedical science, in one of those degrees that I was talking about, you need A levels and GCSEs or equivalent if you're studying in Scotland. So those would be your hires. And you would develop like a very, very broad knowledge, but also very in-depth in terms of the human body, in terms of the science behind it, the biochemistry, the immunology. It really, really, really is a very broad degree. And you also learn a number of skills for life. So it's not just the sciences. We get to do a lot of statistical work, a lot of bioinformatics. We get to learn a lot of digital skills. But then also because it is a degree, you are going to get those skills that you would get from all degrees, like time management, problem solving, critical thinking, working with others. So I think it gives you skills that are highly valued by employers, no matter what you want to do afterwards, whether it is biomedical science or not. And so this is just a final slide from me about infection sciences specifically, because I'm going to hand you to Georgia. So as I said, it's all about studying microorganisms. So these are things that generally you can't see unless you count some parasites. So these are very, very tiny things like COVID-19, which can cause us a lot of issues, as we know. And so Georgia is training to be a virologist, so a biomedical scientist that specializes in virology. And she'll be talking to you about what she does. So take it away.
Hi, I'm Georgia, and I finished my biomedical science degree last year, so that was May 2020, so just as COVID was kicking off really. So I'd actually secured a job at Public Health England before I completed my degree, so I'd secured a job as a healthcare science support worker. So these are the people in the lab that assist the biomedical scientists. They carry out the majority of the tests that the biomedical scientists will then go and diagnose from what has come of that test. And then about 4 months ago, a position came about at Public Health England for a trainee biomedical scientist. I applied and I was actually successful. So now I'm a trainee biomedical scientist. It means that in order to, because a biomedical scientist is a protected title, you're not allowed to call yourself a biomedical scientist unless you're registered with the HCPC. So you have to complete a year-long portfolio to basically say that you're up to the certain standard that these guys put in place, so you can provide the right accurate results. You have a whole lot of responsibilities as a biomedical scientist. So it's a year-long portfolio, a lot of evidence, a lot of my own work so then I can get a certificate of competence so I can work as a state-registered biomedical scientist. So my typical day at the moment, I'm training down in virology, but I will actually be in bacteriology as well. So in virology, it is a lot of automated work. So I'd go in, set up the analyzers. So virology, the majority of the samples we're testing are bloods. So if you're HIV, your measles, your mumps, cytomegalovirus, any like bloodborne viruses. Set up my analyzers. A lot of work in virology is surrounded by quality control. So quality control is very important in biomedical science. It's like Joana was saying, there's lots of different aspects of biomedical science. It's not just going in and testing samples. It's very broad. Setting up the analyzers, running samples, then it's verifying results, which at the moment as a trainee I'm not able to do. You have to be a state-registered biomedical scientist to send out results. Bacteriology is slightly different, so this is more hands-on. You're looking at plates, you're picking colonies, so actually looking at the different types of organisms that are growing. So as a biomedical scientist, you hold a lot of responsibility. At the end of the day, it's a patient's life you've got to take into account, the treatment that's best for them. So you do hold a high level of responsibility. You have got to have good attention to detail. And one thing I've learned throughout my degree and throughout the beginning of my career, you have to be organised. Being organised is key. If you're not organised, you might struggle. Was there any other questions? Is there anything that I didn't cover?
That's fantastic. Thank you so much both for sharing your knowledge and your experience. I guess what I'm really curious about is to understand where studying biomedical science in university can really take you. I know Joana has done a path. You have gone on your own path through Public Health England. So I guess it would be really interesting for our mentees to understand all of the opportunities that can be unlocked with a similar degree and similar expertise.
I'm sure Georgia will agree. I mean, we studied in the same place, we did the same degree, just at different graduation years. And so many of our friends have done so many different things. I know people who are working in labs, so as I described, they may be research or clinical labs, but I also know people like myself who are now studying medicine, others who are doing other degrees. I know of people who are working in science publishing, so working in journals, and people who are going into teaching. There's really all sorts of careers here. Don't you agree, Georgia?
Yeah, I do agree. I think that's the beauty of biomedical science degree. It opens so many doors and opportunities. You don't have to go on and become a biomedical scientist. And even if you do, there's plenty of other opportunities later on in life. You can always go on to postgraduate study later on in life as well if you decide that's what you wanted to do. But yeah, a lot of my friends have gone into laboratory work, scientific writing. There's a whole heap of opportunities out there with a biomedical science degree.
I think the key is that what we study, it's not just your biology and chemistry. It really is really varied. So we do a lot of anatomy, as I've said. I think we also do a lot of bioinformatics, so to teach you the more digital side. I know a couple of people who've gone into postgraduate degrees in the bioinformatics side. And we also have, obviously we do have your sciences, and we have specialized modules in things like microbiology, immunology, pathology. But it's all to give you like the broadest base of knowledge that is possible, because people go off to do so many different things that as a university, they need to prepare you for all these different paths. And even when you then start training to be a biomedical scientist, like Georgia is doing, you can then do different specialisms. So there really is a lot of opportunity for you to change path and for you to try different things and see what works for you. And I think that really is the beauty of it. In my case specifically, although I am studying medicine, the 3 years that I spent studying biomedical science were not a waste. I learned so much, and I wouldn't be as prepared now if I hadn't done it. And I did work in clinical lab between my first degree and now medicine. And it was an amazing experience. I loved it. It really is really interesting. You're just dealing with so many samples. We're talking in the hundreds and thousands if you're in a big central hospital. And each of them is a person. That's what you have to keep in mind. They're not a sample. They're a person who's waiting for those results. And that becomes very real when you start seeing things like very, very, very tiny test tubes that have bloods from babies who are really, really sick. And you're just extra careful with those because you really don't want that child to go through any more pain. That's the same with anyone else, right? I think just being a child, for me, I remember when I saw my first, those really little test tubes, and I thought, oh my God, this really is serious, this is real. And yeah, I really love the profession. I think it's something that most of us take for granted. You go to your GP, you take bloods, and somehow the result comes back. And there are a lot of people involved in it, and biomedical scientists being a key player, but not the only ones working in the lab. So Georgia's talked about being a support worker. You've got your medical lab assistants, which do a similar job. And then you've got a lot of other people involved in validation of the results, quality control of the machines. There are a lot of people involved, but sending a sample off and getting a result, it's not as simple as it sounds.
I think that's what a lot of people don't really understand it. They don't know, because a lot of the work is behind the scenes. Like you say, you send in a sample and you get your result. You don't actually know what goes on behind the scenes. Another thing I did want to add about the portfolio to actually becoming a biomedical scientist, the registration portfolio it can be covered over any discipline. So I'm I work in microbiology, so I'm doing my registration portfolio. But then if I decided next year, or when I've done my portfolio, I wanted to go and work in biochemistry, I can. Doing the portfolio in one discipline doesn't limit you to that area. If I then wanted to go on and do a specialist portfolio, then that would be more where I kind of specialise in a certain area. So specialise in microbiology, haematology, biochemistry. So that first stage, actually registering as a biomedical scientist, you have got a lot of opportunity. You can do your registration portfolio and then move to another discipline if you want to get a flavour of what goes on in the other labs.
I know they're really competitive, but I know that there are certain trainee biomedical scientist posts that are rotational. So I know someone who's doing one of those where he spent 3 months working, say, in microbiology, like what Georgia was just saying, then you do 3 months there and 3 months in another place, and you do your portfolio in this very balanced way. The reason why that's possible is exactly because your first registration portfolio doesn't limit you to a discipline. Specialisms then start to limit, but then if you have like a very, I don't know, if you're really excited for a completely different field, then you can just do another registration for specialism, I think. I don't know many people have two, but I guess technically you could.
Yeah. That's fantastic. And I think that realistically, even as medical students, we don't really know what goes on behind the scenes. And a lot of times we're just like, oh, just take a blood culture and send it, but we don't really know, the process that is behind getting those results back. So it's been a really, really interesting conversation, and thank you again for your time. I guess I just wanted to ask you what advice you would give to our mentees who are in sixth form, so year 12 and 13. Some of them are actually very keen and follow us from year 10 or 11. So is there any piece of advice that you'd like to tell them, or anything at all?
I'd just say that work hard. It's an amazing career. It opens so many doors, and if you are a bit on the, I'm not sure what I want to do, but you are interested in science, biomedical science is an amazing degree to go for. It opens up so many doors, so many opportunities, and you're not limited. That's it really.
Absolutely, I echo what Georgia's just said. It's broad, as we've said throughout this talk, but if you love science, this is the degree for you. If you're not sure what you want to do next, we know that you love science, you maybe like studying biology and chemistry at school, then this is definitely the degree, because you're going to learn about a lot of things in depth, and perhaps that's going to help you make your decision at the end. I know many people who wanted to do something their first year and then completely change their mind halfway through, and that's the whole point of going to university. It's for you to experience different things and then make a decision. And in terms of the sciences, I would say biomedical science is definitely one of the best degrees to do that. If you want to explore the biology and the chemistry, that's the way to go.
Yeah, I agree. Fantastic. Thank you so much. So I'm sure that so many of them will be really interested in this and will want to know more about your career and what subjects you study, etc., etc. So is there any YouTube channel or any website or book that you particularly suggest that they check out?
Personally, like Joanna mentioned, I'd say the Institute of Biomedical Science, that website covers absolutely everything, from down to actually being a biomedical scientist to being a biomedical science student. It's got everything on there, so that's really going to be your go-to and the hub of learning about what biomedical science is.
100% IBMS is the way to go. The information on their website is very easy to follow. I'd also follow them on Twitter, because they do very frequent IBMS chats where they have actual biomedical scientists who are on Twitter from a certain time, and you can just tweet them stuff and they'll answer it. They usually have a different topic whenever they do it. I don't know if it's weekly or monthly, but they do have a schedule to it, and that's a really good way to engage with them. So yeah, IBMS website, definitely the way to go. There's also the NHS Health Careers website, and there's an equivalent in NHS Scotland. They have a lot of very good information about different pathways in healthcare, actually, not just biomedical science. But their biomedical science page is really comprehensive, so I think that's a really good place to go. In terms of the live event, I will be there live, not just offline, so I'm happy to answer questions.
Fantastic. So thank you again so much, and good luck with your future endeavors.
Thank you.
Bye-bye.
Thank you very much.
Bye.
So thank you all for staying with us until this time. We've now reached the end of our webinar, where you guys can write down questions for the Slido. Meanwhile, please type these links for the feedback form and the Google review The feedback form will also generate a certificate of attendance for you, which you can keep for your portfolio or to prove that you've been committed to learning more about the medical field and healthcare in general. And the Google reviews are really, really important for us because they're a way that we can show how much of an impact we're having on young people like you in order to keep some funds from sponsorship coming in and continue providing us with these experiences. So please make sure to do them, and please make sure to subscribe as well if you haven't subscribed yet to our YouTube channel. So I guess we can leave these on, and we can cover many of the questions that have come through. So I guess this is a good one. A question for all speakers: what makes a good shift for you if you work, if you do shifts? So nurses, midwives, and physiotherapists alike, I guess. What would you say makes a good shift for you?
Oh, I'll start. For me, for a good shift, it would be good teamwork, good communication, and good staffing. I mean, if you wanted an ideal shift, a full complement of staff would be fantastic. It's very rare you get that nowadays with COVID, but yeah, full staff, good communication, good teamwork. That would be a good shift.
I completely echo that. I think that good communication and good teamwork really make the foundation for a good shift and make you able to face any kind of tough situations that might come up throughout the day. So having people that you know around you that can support you, help you with difficult situations. If patients are really struggling, knowing you have someone to turn to in case you have a question, or you're really tight on time, or you just need some support and help and somebody to be there. That will make a great shift for me, and then everything else we'll manage to deal with.
I definitely agree with both of you, and I think I would definitely go on to say that part of what makes a shift good is even just thinking I've done one good thing from this shift for someone, even if it's for one of your colleagues because you've managed to help them do something, or even if it's for yourself, just feeling like you've done one thing really well to be proud of. But yes, definitely the team you work with, the support you have, and a good staffing level will be lovely.
Yeah, and the only other thing I would add to that, and maybe this will sound a bit weird, I really like the shifts that were busy. So when you had lots of things to do, although sometimes it can be a pain to just, you feel like you're making a difference. Like when you have, in my case, when I had like tons of samples to deal with and lots of people to help, it makes you feel good. It makes you feel like you're making a difference. So sometimes the busiest shifts are definitely the best.
Sounds good, thank you. We also have a question for Sian. How has your job changed since the pandemic? And I guess this can really be answered by anyone because it would be really interesting to understand more of this.
So in midwifery with the pandemic, we wear a lot of the PPE that Michaela was showing. So it's not as bad as how it has been for some of like the real red COVID zones. But in midwifery, basically, obviously some women do come in with temperatures and we have to treat them as if they potentially could be COVID positive. Wearing the full gear while someone is in labour is quite scary. I mean, labour can be very scary for women anyway. So if I'm then covered, face, mask, everything, you kind of sometimes lose that personal touch that I think Michaela was touching on in her presentation. So our women, we're starting to reduce it down now, actually, the PPE. We found that with COVID, the numbers getting better, we don't have to wear as full amount. I mean, it was very difficult at the beginning where you'd be in a shift for 12 hours with a woman in labour in a room and you couldn't leave, and she was in labour, and of course it makes a very hot room and you're in the gown, and that was quite difficult, but it is getting better, I think. We did have teething issues with care for our women at the beginning, where appointments were being stopped or they were going virtual, and that's very difficult to assess someone's well-being over a telephone. So we're able to bring women back into clinics better now, and I think care is getting better. We're having a lot more births. Lockdown has created a big boom in births. As much as there were some articles that were saying that the UK wasn't getting a birth, I don't know where they get that from. We are having a massive birthing boom in my hospital. So yeah, very big baby boom at the moment.
Anyone else has had pretty major changes to their work routines? I imagine, Michaela, your job, as you mentioned, has gotten quite tough over COVID, particularly working in the intensive care unit.
Yeah, so in intensive care, we do a lot of aerosol generating procedures, which means that we do have to wear the full PPE. And for a large period of time, when we were having a massive influx of admissions, one after the other, it meant receiving people with either a confirmed COVID swab or a pending one in full PPE, and being in the room with them for like up to 4 hours, trying to settle them and get them stable enough to be able to be left for us to go and doff our PPE and wash our hands and go for a drink. And as Sian was saying, it's a lot when you're in a warm room and you've got all this gear on, and you just, the minute you get it all on, you can guarantee that's when you go, I've got an itchy nose and I'm desperate for a drink, or I need the toilet, and you have to just sort of put that out of your head for a couple of hours. And normally that wouldn't be the case for us. We would just be in very basic level pinny type PPE with the gloves, and that even can sometimes get on people's nerves if it's like a hot day particularly, or there's a lot to do for someone. You sit there and I'm sweating, I'm this, I'm that. But it's so, yeah, I think it has impacted from that point of view. And I think even just a morale point of view, after a certain point, we obviously got very exhausted physically, mentally, emotionally, and it does take its toll eventually. In any setting, whether you're a very red COVID zone or not, it's you'll get staff sicknesses, shortages, somebody's relative, even perhaps your relative, might come down with COVID, and it all does impact you, even though you kind of have to stand there and take a whole, I'm a professional, I need to do this, I need to do my job. We are only human, and it does affect us in different ways. So I think everyone's job, as you said before, rightly so, has been affected by COVID.
Sure. I guess we'll take just the last question, because we've been going on for a while. And thank you so much, guys, for following us until this time. I was just wondering, in a few words, really a few, why did you choose the career you chose? And that's a question for everybody.
I think with physiotherapy, for me, it was being somebody's main advocate and always being in their corner and fighting for what's right for them.
Thank you so much. That sounds really nice. Who's next?
I think for me, it was curiosity. I was really curious to see what was behind the scenes, and I always liked science, so that's why I chose biomedical sciences.
Thank you.
I think for me, very similar to what's been said so far, but just the desire to care and help people. And it's a very loving profession. And I think being able to spread that love and to be able to support people and advocate for people was definitely the main reason.
Thank you so much. And Sian, you're the last one.
Yeah, I would agree with all of the other sentiments that everyone said. Providing good, safe care, compassionate care, and providing a really good experience as much as you can.
Thank you so much for your time today. It's been a really, really great learning experience for our mentees. Thank you, mentees, for engaging with our questions. Thank you for staying with us so far. Please remember to leave us a nice comment on the Google reviews. They are really what keeps us going. And as many of you might know, this is our last webinar for the academic year. This year, we've done 13 webinars and a 2-day conference. It's been it's been a little bit tough sometimes, but thank you so much for following us, because it's really, really meant a lot. And we will run some further activities during summer when all of us are through med school and we have done our exams. So good luck with your mocks, and please follow us on social media if you would like to be updated regarding our next events. So thank you so much, and thank you to our speakers as well. You've been amazing. And thank you, Charms. See you next